So I'll be speaking on femtosecond laser assisted keratoplasty. And this technique also I learned from Himanshu sir. And I seen him operating around 7-8 years back. And now I'm doing quite a few femtosecond keratoplasties. No financial disclosures. So these are the weapons of ophthalmologists. We all know that, but it won't be wrong to say these are the old weapons of ophthalmologists, because now femtosecond laser is there to perform most of these steps that we are using: knives, blades, and crescents, keratome, everything. So femtosecond is an excellent cutter in the cornea. We can perform any incisions, any shape, or anything in the cornea. So femtosecond laser is a photodisruptive infrared laser with a power of 10 to the power minus 15. It works, it is based on the principle of photodisruption, in which thousands of laser pulses are connected together in a raster pattern to define a resection plane. Then this gas and water are absorbed or liberated to perform a resection cleavage plane. So we all know that manual keratoplasty is time-tested, most successful organ transplant. Although there are different surgical challenges like the problem of trephination, the problem with the sizing, the ledge issues, then suturing, the correct technique, the appropriate tension needed for any case, high astigmatism in post-operative period, high endothelial cell loss, and then delayed visual rehabilitation. So to overcome all these challenges, now we have a another important thing in manual keratoplasty is that it only provides a classical vertical incision. These wounds require relatively tighter sutures to withstand the effect of intraocular pressure, which leads to high astigmatism and healing of at least 1 year. And after that also, the chances of wound dehiscence after suture removal is up to 4% of cases. So to overcome all these problems, now we have femtosecond laser. It has the ability to perform incision of any angle at various depths within the corneal tissue. It permits full thickness graft with peripheral lamellar wound configuration. It works with greater precision in finite control and in automated manner. There's a minimal donor tissue manipulation with femtosecond laser, and which causes less endothelial cell loss during the procedure. Another advantage with femtosecond laser procedures are it provides greater surface area because of its customized shapes. A manual PKP wound is vertical, as I've discussed. The variation from this type of wound is not possible with manual surgery, but when we go with femtosecond laser, we can make any shape like top hat, mushroom, zigzag, or any other configuration which is needed. So how to choose which kind of incision suits for which surgery? So for example, top hat shape configuration, it removes lesser of the stromal tissue and more abnormal endothelial tissue. So it would be good to do in cases of pseudophakic bullous keratopathy. In cases of keratoconus, where the corneal stroma is a problem, mushroom shapes works well because it removes abnormal stromal tissue and saves more endothelial tissue. Whereas zigzag shape, it provides excellent wound seal because the angled edge provides a smooth transition between the host and donor tissue. So how femtosecond laser cut the cornea? So basically the femtosecond laser cuts in 3 planes. But first it makes the posterior side cut, which is a cylindrical cut from the anterior chamber into the stroma. Then it makes the lamellar cut, which is a planar ring-shaped cut parallel to the anterior surface. And the last cut is the anterior side cut. It is a cylindrical or arcuate cut from the stroma proceeding anteriorly to the epithelial surface. So because of this multiple planar cuts, the wound seal is always better. So there are studies which have compared femtosecond keratoplasty results with a conventional penetrating keratoplasty. And this was in keratoconus. And the study have shown that the BCVA was better in all femtosecond cases, and endothelial cell loss is also lesser in femtosecond group. And they found that it is a safe and better procedure than the conventional PKP in keratoconus. So there are different platforms which provide the opportunity to perform femtosecond keratoplasty. And this was one of the video which I performed in corneal scar case. With the advanced machines where we can play with the energy, we can perform femtosecond laser with in corneal scar cases also. And like this machine is the intraoperative OCT, so you can see where you're going to cut. And this is the anterior chamber. You have to mount the cornea on this, remove the loose epithelium, and then apply suction. And once the suction is complete, centration is fine. Again, look for the OCT pictures. make the necessary adjustment, and then to the resection. You can see the gentle peeling of the tissue is required. No cutting is needed. This is another case where you can see the nice ledge, symmetrical. Suturing is very simple in case of femtosecond keratoplasty because the ledge, the donor tissue nicely sets in with the recipient. You just have to put small sutures, and suture numbers can be less. You don't need to put 16 sutures always. If the graft size is less than 8 millimeter, 12 sutures works equally well. The length of the suture is smaller than the manual keratoplasty. And people have also started using glue with few sutures in some of the cases. You can see the nice apposition of wound and the donor and the host. And this is a photograph of the ASOCT post femtosecond PKP. The wound transition between the host and donor is clearly visible. You can see the nice transition is there, which shows that the position is excellent with femtosecond keratoplasty. This is another paper which talks about femtosecond role in laminar keratoplasty. Dr. Rajesh has already covered. It works very well with the anterior laminar keratoplasty cases. So this was one interesting case of recalcitrant epithelial growth, where after several maneuvers, the epithelial growth came back. So we performed femtosecond keratoplasty for this case. So in such cases, femtosecond is very useful because intraoperatively you are seeing everything, that you're not missing any scar or any epithelial cells. So you can cut accordingly and modify intraoperatively. Another important factor in femtosecond keratoplasty is that you don't need to take an oversized graft. In most of the cases, same size graft works well. So this is a donor. You just gently have to lift up. And this is a post-op photograph of the same patient, and we can see nicely attached graft. This is another interesting case of central corneal scar in which the periphery is clear. So we went ahead and planned a hemi-automated laminar keratoplasty for this case. And after measuring the clear zone, the cut pattern is designed on the femtosecond laser. In this case, what femtosecond laser, how it helped in this case, it makes a planar cut around the corneal opacity. So we get a uniform plane all around it. So it's very easy for us to enter with the sharp crescent and stay in the same plane, because from all around you are in the same plane. So gently we have dissected this tissue. So this is a hybrid technique with femtosecond laser as well as some manual steps. And then this is the donor tissue of the same size. You gently have to remove the epithelial bridges with the help of Sinski and then lift the tissue up. Most of the time, there are no tissue bridges because of the appropriate use of energy. And then suturing is done. And this is a post-op photograph of the same patient. You can see the nicely attached graft with no overriding or any haze. And femtosecond enabled DLKs are also being done from last 1 decade. But till now, the femtosecond assisted DLK was in that the ASOCT or pentacam used to be done to measure the thinness spirometry, and then we have to cut less than 100 micron or 80 micron up to the thinness spirometry, and then we try big bubble, or if the interface is clear, leave the remaining stroma behind and suture the graft. But with the newer femtosecond laser like Z8 machine, we have the added feature of making a tunnel for air injection. So this tunnel, you can play with the length, the angulation, the width according to your cannula size. So this step makes this femtosecond laser more predictable. This dark procedure more predictable. The chances of getting air big bubble is quite high. This was Another case done on this machine. So this is a lamellar cut made with femtosecond laser. You can see this is a tunnel made with the femtosecond laser. And then air is injected in a same plane. Chances of perforation is extremely rare with this software. And then air is injected, and then the dissection is done. The graft is sutured. So now femtosecond laser has come with the inverse ultra thin dissect technique also with the 𝐁𝐨𝐸 machine, where you have to mount the cornea up endothelial side up, and they claim that if you press it with the handset with the machine, it will not damage the endothelium if you go vertically, and then it makes two pockets and a lamellar cut. Then you have to open this pocket with a blunt spatula, and then trephination is done, and this lenticle is used for the dissect surgery. I've personally not done this inverse ultra-thin dissect, but maybe in future I'll perform this also.
So sorry to interrupt you, but the time is up, so I would request you to please wind it up.
So in conclusion, the femtosecond laser gave new dimension to keratoplasty techniques, from PK, ALK, DLK to dissect. All the surgeries, it has its role, and early visual rehabilitation, less astigmatism, and ease of doing surgery are the main benefits of femtosecond keratoplasty. Thank you.